Thank you. Disclosures are shown here, some are relevant. So we see that there is an unmet need for treating type A dissections. A significant portion of patients are turned down from surgery. In our analysis, we found 8% of those patients were turned down, and 2/3 of them, if they had an option, we'd probably like to treat them. We had a lot of experience because of this with off-label use of stent grafting in the ascending aorta, and we learned a lot of lessons with that experience. One of which was that the challenges to proximal TEVAR, as we've already heard from Rod White, are about the anatomy and the morphology and physiology in this region, but are also procedure related. This ascending aorta component is short and curved, and we really have to be coaxial at the sinotubular junction to avoid the valves and the coronaries. Fortunately, we've had experience with this device from Gore, the ASG device, in its newest iteration, and now offers a broader offering up to 53 millimeters in diameter, and it comes in lengths between 7 and 10 centimeters, which is a proper length for the ascending aorta. But what's unique about this device, and for time, I'm not showing the whole deployment, but you see after it's partially deployed, this is what's unique, is that we can change the shape of this to adjust it so that it gets coaxial at the sinotubular junction. And then it gets fully expanded, and then you can adjust it one last time, a little different than the commercial C-TAG devices that you have for the descending aorta right now. What we've also learned when we treat these patients is that we have to understand how the disease heals around this. This is one patient who still had a little endo leak after we sealed off that type A dissection, but by 6 months it had completely healed, and we got an excellent result like this in this DeBakey type 2 dissection in a very high-risk patient who, like Rod's patient, lived for a few more years but otherwise would have been turned down. And we published our experience with the EFS series. 19 patients were able to be enrolled in that series, and you can see the total enrollment in this during this EFS experience was 43 patients. There was those 19 who met the enrollment criteria and 24 who were in E and C. That paper was just released yesterday. And what we saw as the outcomes in this group were pretty good for a very high-risk population of patients. These are acute dissections that were turned down for surgery. The mortality was 16%. And in that E and C cohort, we saw similar outcomes with a mortality that was quite acceptable, again, for a very high-risk population of patients. Of course, there's a lot of questions to address. What do we do with the aortic valve? How do we partner these things with transcatheter aortic valves? How do we define these highest-risk patients? We're also learning that there may be other roles for this technology. We heard the one suggestion from Rod about maybe treating patients sooner, but also it may serve as a bridge. This guy came in with a rupture. We sealed off the rupture. Later on, we saw an endo leak. The guy looked way better, so I took him to surgery and did a more formal reconstruction of his aorta, and he's here to tell us that these devices may be complementary and not competitive to ascending aortic surgery. What's coming next? Well, in our experience, ascending stent graft still plays a role, and when we're in the process at our center of creating an ASG PS IDE to continue to enroll acute dissection patients as part of our treatment paradigm, and any day now we should be enrolling our first patient in the ARISE 2 pivotal study. This is more elective patients. These are patients with pseudoaneurysms, chronic type A dissections, and other isolated lesions, a lot like that E and C cohort that we saw. We currently have 31 sites that have gone through the process and are about ready to enroll patients very soon. We'll see these two configurations for the ascending only arm as well as a TBE zone 0 arm. And then we'll also see maybe this technology expand into the aortic root. The group in Brazil, Diego Gaia, described this in 2020 and just had a discussion with Mark Taylor at University of Maryland. This was one of their cases. They've already done 5 of these endobental operations. You can see the very nice post-op result in that patient. Of course, endocomposite valve graft will have serious issues with proximal fixation and seal with regards to tying it together to both a transcatheter aortic valve and covered stents for the coronary arteries. But I think this is a very ripe place for innovation, and we'll continue to expand the use of these devices in this space. Thank you very much.